Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Today, we'll be speaking with Craig Mullen about the root cause revolution, which essentially means a functional medicine approach to health. Craig Mullen is a nurse practitioner who's the founder of Remedy Functional Health Solutions. Craig, thank you so much for joining us today.
Hey, thank you very much, Dr. Weitz, for having me on the show today. I am excited to be here and thrilled to have this opportunity to talk with you this morning.
So where are you located? What part of the country are you in?
I am in Salisbury, Maryland, which is a little portion of the state on the eastern side of the state that is adjacent to the coast. We're about 30 minutes away from the Atlantic Ocean. So it's a nice spot to be. Definitely is an exciting time for the area because we've got an influx of people coming to the eastern shore over the past decade. We've got a great university here in Salisbury that has excellent exercise physiology and exercise science programs, as well as a pre-med program. So great time to be here on the eastern shore of Maryland.
And I'm speaking to you from about 20 minutes from the West Coast, from the Pacific Ocean. So
awesome.
The powers of technology. So what made you decide on your career path to become a nurse practitioner versus some of the other choices? Could have included being a physician's assistant, an MD, or some other kind of doctor.
Sure. So my father was an oral surgeon for about 40 years. So I was pretty well acquainted with the healthcare system by the time I was at the point where I needed to start looking into careers. Felt very comfortable with, health and science and whatnot. Actually went to school initially for a philosophy degree.
Me too. I got a philosophy degree from UCLA.
Nice. Yeah. It's a great field to be in. It really teaches you how to read. It teaches you how to, formulate.
How to ask good questions.
Exactly. Ask, the important questions.
Be skeptical.
Right. You write a lot of papers, get exposed to a lot of.
Yeah, I was going to get a PhD in philosophy.
Yeah. Excellent. So I did that. And then, the natural sort of inclination for a lot of people who are in philosophy is either, do that, which is go on and do graduate studies in philosophy, or, potentially become an attorney. So I started prepping for the LSAT. And then rapidly sort of did an about face and realized that this is not what I'm looking to do for the rest of my life. No, shade to attorneys or anything, with regard to practicing law. But at that point in time, I've always been very interested in science. I've always had a deep fascination with wellness and health. And so there was the option to pursue what's called a second degree or accelerated pathway to nursing, to get your registered nurse, your bachelor's of nursing science. And so I took part in that program. But going through that whole trajectory, I knew from the most early stages of taking the classes that I wanted to have the diagnostic and prescriptive authority and privilege. And it really is a privilege. And so, very early on, my sights were set on the natural next step, which is for a nurse to become either a nurse practitioner or, pursue a couple of other different avenues, such as nurse anesthesia. You can be there's a couple other pathways, but those are the main roles that nurses who seek advanced practice roles, usually pursue: nurse anesthesia or nurse practitioner. And I knew that being a nurse practitioner would allow me the flexibility that I wouldn't necessarily have as a nurse anesthetist, to, open my own practice and, see patients in different areas of the discipline, whether it's outpatient or inpatient. And so ultimately got my family nurse practitioner degree from George Washington University, worked in primary care for a handful of years in the urgent care and immediate care settings, especially so during COVID or during the early years of COVID. And from there, I actually went back to school, did some more training at Drexel University to get what's called an acute care certification, where you can practice in the hospital, in critical care settings or in medical surgical settings.
So your current practice now, you have your own practice and you also do some emergency or acute care?
Yes. Yep. So I still work on a part-time basis with a local hospital. It's Atlantic General Hospital. And I work with a hospitalist team there. I do like 4 shifts a month on average. Used to be, 12 to 15. But since I've started my practice, this has become my real true passion. And it really is. It always has been health span optimization, keeping people out of the hospital, keeping people off of prescription medications if we can, really trying to mitigate the risk for chronic disease, not allowing it to set foot in people's life, to begin with. And if it is present, doing everything we can to halt it in its tracks and reverse that pathology so that we can help people live a more vital existence and add quality to their years, not just years to their life.
And I think the need for this kind of care and the type of practice I have with functional medicine and many others do is ever more needed. There was just a report that the United States is doing poorer than most of the other advanced countries at reducing chronic diseases. And in fact,
100%.
Among Americans aged 20 to 40, we're seeing an increase in chronic diseases. So we really desperately need a functional medicine approach that's going to look at diet and lifestyle and doing something about the root causes of cardiovascular and these other chronic diseases rather than just treating their symptoms as they go downhill.
Right, exactly. We're just as you were saying, we're seeing an increasing incidence of terrible vascular events in younger people. I mean, we're talking about myocardial infarction, heart attack, as well as increased incidence of stroke among young people. So very important that everybody start to address these issues now. We're really having it's a struggle in America currently. Our health system spends more money per capita compared to other industrialized, first world nations. And we have one of the sickest populations despite that. So
yeah, it's about time we start preventing these chronic diseases and keeping them from getting worse rather than just treating the symptoms. So I listened to a few of your other podcast interviews, and I think our approach to functional medicine analysis is fairly similar. I know you, like I, like to do very detailed testing, including a full thyroid panel, advanced lipids, hormones, nutrient status, as well as the basics. And doesn't it drive you crazy when a patient shows up in your office and they say they went to their primary doctor and their lab showed they were in perfect health?
Yep, it really does. Yeah, because, patients are potentially being misguided in situations such as that. And, they also feel like they're not being listened to because they feel as though something is amiss, something is awry. They're waking up. They don't have the energy and the get up and go that they had in maybe their younger years or before a bad infection or a severe stressor that they experienced. So now they have some disruption in their life, and they have brain fog, they have fatigue, and they're not sleeping well. They are having difficulty meeting the demands of their life, whether it's kids, job, other things that they have going on. They're just having more difficulty meeting those demands. And it really does entail that we take a deeper look into what's actually going on at the cellular level, and looking at some of the biomechanics of, how are these organs and whatnot actually functioning, whether it's the thyroid, which sets, the metabolic rate for the body. How are we detoxifying through the liver, and how are we absorbing nutrients through the gut, and all of these things, are critically important.
And when these patients say they've had their labs done and they get the impression that every lab that would be beneficial was done, what they don't realize is that the only labs that they had run were what insurance wants to pay for, which essentially for most patients is a CBC and a chem screen, maybe a basic lipid profile. If they get thyroid testing, it would probably just be a TSH. And so really, of the thousands of potentially beneficial tests, they had 5 of them done, and they think that's all the labs that could be run.
Right, exactly. And sometimes these, are only being run once a year. Sometimes
typically once a year. And by the way, the ranges that are looked at are what's called the reference range, or essentially corresponds to what the average American's levels are. And to me, that is completely insane, since we know the average American is metabolically unhealthy and unhealthy from many other perspectives. And just looking at the range comparing you to an average American is really doing a disservice. We need to be looking more at what we would call an optimal range.
Exactly. Yeah. I mean, something like a reference range for insulin that has an upper threshold of, 24.7 is absolutely, it's mind numbing how, concerning that is. Insulin, as you well know, should be a marker that's, 6 or below, when we're really looking to optimize, glucose metabolism and such. And so, people are walking around with, a lot of metabolic insufficiency, and they're contributing to these chronic inflammatory patterns.
And your average primary care doctor is only going to flag it. First of all, insulin is usually not run, but even if it was, they're only going to flag it if it's in the red. And
exactly.
And so they're not really looking at that. And I recently had a patient who I looked at their labs, and their liver enzymes were high, but they were still in the reference range. So apparently during COVID and afterwards, people were drinking so much and eating so much unhealthy food that liver enzymes went up. So UCLA raised their reference range for AST from 40 to 70. So now a patient with 60 is considered normal, and that's completely insane.
Yeah, that is incredible. I haven't seen that yet over here, but that is wild. I'm astonished.
So patients need to know that the reference range is comparing you to the average American.
Exactly. And we've seen how over time that's changed with regard to other things as well. If you look at a hormone panel for men, 30, 50 years ago, the upper threshold of normal was not going to be in the mid 900s, and the lower threshold was not going to be in the 300s. It was closer to, a range of 500 to 1200, previously. So
I see some labs where the reference range is 150 on the low end and 1,000 on the high end, which is like ridiculous.
Yeah. Crazy.
So let's talk about some interesting cases where you did some detailed testing and figured out that the patients were off track. And I thought maybe we could start with thyroid.
Sure. So I see a number of thyroid Hashimoto's patients in my practice. It's
by the way, for those who are not familiar, what is Hashimoto's thyroiditis?
Yep. Hashimoto's thyroiditis is the most common cause of hypothyroidism here in the United States and in the West. It's associated with an elevation in autoantibodies or immune proteins that are activated against our own tissue and ultimately contribute to the degenerative changes of our own tissues. And in the case of Hashimoto's, that is thyroid peroxidase and thyroglobulin antibodies are the two that are primarily most seen elevated in conjunction with one another in Hashimoto's. And so it's, one of the most common things that I see in my practice. It often coincides with people that are, starting to notice some changes such as brain fog. They feel, that their energy is poor. They're having, fatigue on a daily basis. They're not sleeping well. They're having constipation. They have temperature intolerance. They have skin, hair, and nail issues. Hair is falling out. They are, not able to, perform at the gym. They're not able to perform at the job. And they're also starting to experience undesirable changes in some other biomarkers. Like, for example, thyroid, hypothyroid states will often contribute over time to abnormal and undesirable changes in lipid profiles. So I see several hypothyroid patients in my practice. It's gotten to the point now where I almost expect that people, when they come to me with certain symptoms, a lot of those symptoms that I just mentioned, I almost expect to see antibodies present. And, I no longer look at the thresholds for antibodies and say, hey, this is an autoimmune situation here. If they have antibodies present, I'm already starting to look at the path towards, how do we reverse this? Why is this happening? And I'm not waiting for, thyroid peroxidase to rise above 30 or anything like that. I'm saying, look, antibodies are present. There's a reason for this, and we gotta, figure this out. And, that involves a multimodal, multifaceted approach. But it's one of the most rewarding things to treat in my patients because you see over 4 to 6 months these initial changes happening, and patients start to feel better quite rapidly once you implement certain interventions.
Yeah, and you've probably seen patients where they're taking thyroid, which is usually a synthetic T4, and yet their T3 is still low, and nobody knew it because nobody measured their T3.
Exactly. Yep. And there's a number of things that will contribute to low T3. I mean, there can be impaired conversion of T4 into T3 peripherally. This is often attributable to certain nutrient deficiencies, to, other inflammatory insults. And so we, have to really look at all those factors, take everything into account. What's their vitamin D level? Are they getting, optimal diet exposure to things like selenium, zinc, copper, other factors that are going to be involved in, conversion of T4 into T3. How's their liver function? Liver and thyroid are very much interwoven with each other. And so if there's dysfunction in the liver, there's oftentimes going to be dysfunction in the thyroid. Another thing that I see all the time is perimenopausal women and beyond into menopause and post who, they're obviously progesterone deficient. Well, progesterone and thyroid also very interwoven with each other, and balancing progesterone is usually always one of, or restoring progesterone really is one of the initial steps that I'll take in women who are having significant hypothyroid issues.
Interesting. Can you explain how progesterone affects thyroid?
Yeah, especially in the context of in immune dysregulation. So progesterone as a hormone is very immunomodulatory, and it helps promote immune tolerance and will really downregulate processes in the body that contribute to immune hyperreactivity. So progesterone, outside of Hashimoto's, it's also been shown to be very beneficial for a number of other autoimmune conditions, such as multiple sclerosis, ankylosing spondylitis, rheumatoid arthritis, psoriatic arthritis. So it has these very immunomodulatory and anti-inflammatory properties that really, make it such a huge, a powerhouse tool to employ and deploy in the treatment of autoimmunity.
That's really interesting. Do you ever use progesterone for men?
I do not often use progesterone for men, but there is, it is necessary for men as well. And I have heard of practitioners who will recommend utilization of progesterone topically, sometimes just applied, along the inner thighs or to the scrotum for, the optimal benefit of progesterone. It's not something that I typically do in my practice. I'm open to it. I'd have to read more into the science of it.
Yeah, I don't know anybody who really does it, but
Yeah.
we get progesterone on the labs, and I see that it's sometimes low. I think the one context in which it is accepted to use it is in the context of traumatic brain injury.
Exactly. Yeah. And IV progesterone, right? So that's one of the things that I really picked up on. Dr. Lindsay Bergstone was one of the ones who first introduced me to that idea, and really profound. Absolutely.
So let's talk about looking at an advanced lipid profile. Why should most patients have an advanced lipid profile? Why is the basic lipid profile so inadequate? And what are some of the important information we can glean from such a panel?
Yeah. So I think, it's really important to also focus on cholesterol. What is cholesterol? What does it do in the body? Well, cholesterol is the precursor. It is the substrate from which our hormones are ultimately generated and derived. Not only that, cholesterol is a major component of cell membranes, right? So the delicate membranes that surround each and every one of our cells that provide some protection and support for their structure. So it's essential as cell membranes are broken down. If we don't have appropriate cholesterol to strengthen the cell membrane, those cells are going to be more prone to damage from oxidative stress and inflammation in the cellular environment. And this will ultimately contribute to, changes in DNA structure and proteins within the cell. So we need to have adequate cholesterol. Cholesterol is very important for overall cellular health. It's critical for brain health. When we look at a lipid panel, if you go to your PCP and you get a standard lipid panel that shows total cholesterol, LDL cholesterol, HDL, triglycerides, VLDL, that's really only part of the picture. And unfortunately, it's a very archaic way of looking at lipids, because we know that, something like an LDL, for example, can have various sizes, and those sizes sizes of the LDL correspond to various levels of risk. For example, if somebody has what could be called a pattern A LDL, which is a larger size lipid molecule, then this means that it skews towards being more of a buoyant, beach ball-esque lipid molecule that's much less prone to contributing to atherogenesis, or the formation of plaque inside the lumen of the blood vessel. So this, in comparison to somebody who has a higher count of small LDLs, or their LDLs skew towards the smaller size, these are much more prone to invade the delicate endothelial tissue inside the vascular bed, which is going to be associated with the development of atherosclerosis and lesions that can contribute to coronary artery disease and cerebrovascular disease. So a lot of people will come into my practice and we run what's called an NMR lipo profile. And they get this wealth of information where we say, hey, your lipids your LDL count may be borderline high, but you skew towards this pattern A, the larger type of the LDL. And we can also see that your small LDL count is low. And so those two things in conjunction with each other does provide a little bit of a buffer against, an LDL, or an elevated LDL. So I think it's very useful to look at it, in that context. It's a much more comprehensive picture. And then we also look at things, for example, like lipoprotein a, which has gained a lot of attention over the past several years as being an independent risk factor for cardiovascular disease. Lipoprotein a is oftentimes construed as a non-modifiable risk factor, meaning no amount of diet, no amount of exercise is going to really change the number that we see there on the lab. And so it's very much genetically determined. If we look back at what lipoprotein a does, well, it's an adhesive protein found on the outside of the cholesterol particle that probably dates back, hundreds of thousands of years in human evolution when we had no vascular intervention. We had no adequate medical care to heal an acute injury. And so this particle or this compound, lipoprotein a, would be the type of thing that if there was vascular injury, if there was an acute issue that needed to be dealt with, it is very sticky and it'll adhere to the lining of the blood vessel and signal all these chemokines and cytokines or molecules, that will ultimately initiate and incite the repair process. But at the same time, it's also going to result in more platelet adhesion and the adhesion of other repair factors that are found in the blood that can ultimately gunk up or clog up an artery. So it is an independent risk factor. Generally, I like to see that number, less than 90 in patients. The more we can drive that number down, I think is, even better.
I've really been enjoying this discussion, but I just want to take a few minutes to tell you about a product that I'm very excited about. Imagine a device that can help you manage stress, improve your sleep, and boost your focus, all without any effort on your part. The Apollo wearable is designed to do just that. Created by neuroscientists and physicians, this innovative device uses gentle vibrations to activate your parasympathetic nervous system, helping you feel calmer, more focused, and better rested. Among the compelling reasons to use the Apollo wearable are that users experience a 40% reduction in stress and anxiety. Patients feel that they can sleep. Their sleep improves up to additional 30 minutes of sleep per night. It helps you to boost your focus and concentration. And it's scientifically backed. And the best part is you can get all these benefits with a special $40 discount by using the promo code Weitz, WEITZ, my last name, at checkout, to enjoy these savings. So go to Apollo Neuro and use the promo code Weitz today. And now back to our discussion. I think you're starting to hear more and more about lipoprotein A. And the reason why is we're getting set up for some drugs that will be on the market in the next few years to lower lipoprotein A. Right now, there's no drugs that are specifically targeting lipoprotein A. And I think those drugs are going to be big sellers. And the reason why most doctors are not testing for it is because they don't have a drug for it. But aren't there things we can do for lipoprotein little a?
Yeah, I think that, at that point in time, I'd be interested to look at those at the new and emergent research on these medications, because I actually am not familiar with them. So that's very fascinating to me.
Yeah. There's like 3 or 4 that are in clinical studies now and will be on the market in the next couple of years. But
that's fantastic.
There are things we can do now to lower lipoprotein A, aren't there?
So, what I always recommend to patients is that, we need to control some of the other factors, right? So, I try to push my patients away from statins and things of that nature. Not that statins don't have their place, but there are other things that we can do to really sort of improve somebody's cholesterol panel on a large scale. And so what we can do is implement things like red yeast rice. We can utilize citrus flavonoids like bergamot, tangeretin, nobiletin, as well as vitamin E derivatives such as tocotrienols, and use those in combination with each other to have, profound, sometimes statin-esque lowering of lipids. And some of these agents even boost HDL. So we want to focus on the potential benefits of that as well. And then, certainly looking at other, dietary factors in conjunction with.
So niacin has been shown to lower LP(a) by 30 to 40%, in a few patients as much as 70%. L-carnitine has some benefit. CoQ10 has some benefit. Flax seeds have some benefit. So there's a number of nutritional approaches that can help to lower lipoprotein A.
Absolutely.
And then Linus Pauling had this whole concept of how we can use certain nutritional compounds to reduce the ability of lipoprotein A to actually create this stickiness.
Oh, that's fascinating. Yeah.
Yeah. So you'll have to check that out. So what are some of the other important parts of a lipid profile to look at? And also, do you have certain strategies for reducing small dense LDL or increasing LDL particle size? How do we move that LDL advanced profile to a better health?
Yeah, absolutely. I think, diet is where I really try to focus in those patients, highlighting the importance of omega-3s in supporting healthier LDL profiles, supporting HDLs. So this comes in the form of, again, flax, as you mentioned, avocado oil, and other foods that are really dense in omega-3s.
Do you measure omega-3 levels?
I do sometimes. As if somebody is really chronically inflamed, just to make sure that, they have appropriate activity there from an anti-inflammatory standpoint. And, omega-6s as well can be very beneficial to look at, but not in everybody. Everything is certainly sometimes cost prohibitive, and it's the type of thing that ideally, if I could, I would, but it's not, something that suits everybody.
All my patients are getting omega-3 levels measured.
That's all.
So what do you think about HDL? HDL is kind of this interesting molecule that we've thought of as protective, and there have been attempts to try to raise HDL with drugs, and they've proven to be ineffective at lowering risk. And people have tried to look at HDL particle size, and we know that HDL can be beneficial because it can do reverse cholesterol transport. It can take cholesterol from the artery and bring it back to the liver. But other than that, there's still some confusion as how do we know when HDL is higher is it even good or not? Because it's also acknowledged that when HDL gets above a certain level, it's not as functional.
Sure. I think I'd be interested in seeing continued research on that. I always try to shoot for HDL in men and women, definitely above 50 if we can on a standard lipid panel.
Right.
I think once we're seeing HDL levels in the 80s, 90s, then we're getting into the realm of how beneficial is this really. The size and the density of the HDL really does play a role in its ability to participate in that reverse cholesterol transport. So we do have to look at those factors as well when we look at something like an lipid particle size and number.
I think we really need a better test for HDL functionality that's widely available.
Sure. Absolutely. Have you seen anything, coming about and down the pipeline with regard to that?
Yeah, they're definitely working on new tests. I know Cleveland has a test for HDL functionality, but not that many people run it. And I think there's more to understand about HDL and when HDL is beneficial and when it's not. So I think the HDL story is still to be fleshed out and told completely. But in general, having a slightly higher HDL is good versus a lower HDL. I've certainly seen certain approaches where things drastically lower HDL, like, for example, bodybuilders who take anabolic steroids drastically lower HDL. And that definitely is part of their having an increased cardiovascular risk.
Yes. Yeah, absolutely.
So let's go into peptides. I know that you utilize peptides frequently with patients. And why don't we start with America's favorite drugs, the GLP-1s, which make people dance through the streets and sing. And why does every freaking drug commercial have people dancing and singing, and you have no idea what the commercial's even about? But so apparently these GLP-1s now, we're hearing from recent studies, reduce every chronic disease and are like the greatest drugs since, mother's milk. And I've even talked to patients who are taking them for longevity purposes, but I particular am very skeptical. To begin with, I've seen a number of patients who lost a bunch of weight. They lost 40, 50 pounds, and then they gained 60 pounds back. And now they have less muscle when they stop taking them. And I've seen a number of patients with side effects. They tend to lose muscle. They get gut problems because it slows down gut motility. I've seen patients with vision problems. So I'm kind of skeptical. Why don't you tell me about GLP-1s and what's your experience?
I think GLP-1s can be very beneficial. And I think that they have a lot of potential.
By the way, for everybody who doesn't know what we're talking about drugs like Ozempic.
Yep, exactly. Ozempic, Wegovy, that's the generic name for, that's the brand name for generic semaglutide. On the tirzepatide side of things, we're looking at Mounjaro, Zepbound, and then some of the older medications, Victoza, Saxenda. We're talking about liraglutide. There's also dulaglutide or Trulicity. So, a whole class of medications that are basically classified as what we call incretin mimetics. So what they do is they promote a glucose-dependent release of insulin from the pancreatic beta cell, which helps with insulin sensitivity in the body. But they also work to slow the rate of gastric emptying. So the stomach empties into the duodenum, and the rate of emptying of food contents into the duodenum, the first portion of the small intestine, is slowed. So what this does is it acts on stretch receptors at the sphincter there, at the portion where the stomach enters into the small intestine, which then sends messages to the hypothalamus, and hunger centers in the brain, which can influence, satiety hormones and other signaling agents like leptin in the brain. And so,
patients eat less.
Exactly. Yeah. Or they have an earlier a sensation of fullness, and they have a sensation of satiety and being satisfied by the meal that they've taken in. The other aspect is that they do work directly in the brain, in the hypothalamus, in an area called the arcuate nucleus. And this directly influences hunger. And so cravings are reduced. A lot of times there's a reduction in food noise, or what people consider, food noise, and that tendency to want to just, graze and snack and things of that nature. So, multimodal approach with the GLP-1 medication to, ultimately reducing the amount of calories that people desire to take in. And
so how do we use these drugs more effectively than the traditional use?
Yeah. So the real problem comes in when people start, just basically utilizing them as a tool for crash dieting.
So they don't change their diet, they don't exercise, they're not eating any healthier, they're just taking these drugs.
Right. Exactly. They're just taking the medication.
They're still eating junk food. They're just eating less junk food.
Yep, exactly. So, once you get on that cycle, say somebody is eating well below their basal metabolic rate, which is basically the rate at which your body is burning kilocalories throughout the day. If you were to sit and do nothing but breathe all day on the couch, that's your basal metabolic rate. If you start dropping below that, or start dropping below your kilocalorie needs for the day and your activity level, ultimately you're going to enter a state that is catabolic in nature. This is a state of breaking down tissues to supply energy for the body. And so people who are misusing GLP-1s, maybe they are, not hitting their protein requirements. They're not hitting their caloric requirements. They're not hydrating, and they're certainly, not exercising at that point. They are going to have a net loss of muscle tissue. Muscle is the main metabolically active tissue in the body. And so as you lose muscle, you have significant declines in your basal metabolic rate. So look at these patients, several months on, a year or so into their weight loss journey. Yeah, they've lost 40, 50, 70 pounds. A lot of that, if it has been muscle loss, has contributed to a net decline in their basal metabolic rate. And then, they say, okay, well, I've reached my weight goal. I'm going to come off the medication now. Long story short, all of the old habits come into play. They start eating like they did previous, and they're eating the same amount, right? They're eating the caloric, they're hitting the caloric thresholds that they were at previously. And all of that excess calories is being stored again as fat.
So how do we utilize these drugs so that doesn't happen?
Yeah, you've got to make sure that you're tracking people's body composition. I don't see how a GLP-1 prescriber can go through their practice, continue to practice in a way where they're not regularly measuring somebody's body composition. And what I'm talking about in that regard is utilizing a device like InBody or eVolt, something of that nature, where you can actually measure basal metabolic rate, where you can look at skeletal muscle mass to see.
Yeah, we use bioimpedance in our office.
Yeah, it's critical. I mean, so you got to measure for, fat reduction. You got to measure for visceral fat reduction, which is a primary goal. In these
you want to see when they're losing weight, that they're losing fat. You want to make sure they're not losing muscle. And you've got to understand that sometimes people lose water, which is not really fat loss.
Exactly. Yep. So that's, step number one, doing the body composition analysis, and routinely so. The other major components are ensuring that they are hitting their protein requirements. Generally, I recommend anywhere from 1.2 to 1.6 grams per kilogram per day for an individual to prevent that sort of catabolic change where they're losing muscle mass. And then, it's also a major focus that they need to be working on resistance training. And what that means is at a minimum, using body weight, using resistance bands, but really looking to also capitalize at, heavier lifting or utilizing weights, utilizing machines in the gym to, basically precipitate muscle hypertrophy and growth or preservation at a minimum, which also benefits bone density. We see a lot of, older patients who come to us and they've been on GLP-1s and they've become so catabolic that they've actually induced, osteopenic and osteoporotic changes by way of having significant declines in muscle loss and, hydration as well. So
what do you do about the fact that when people stop these drugs, they gain the weight back?
I think that it's really important to nail down those fundamental lifestyle aspects, right?
So if they're going to continue to eat healthy and exercise, do you use a lower dosage so they're less likely to have that kind of withdrawal effect?
Yes. If somebody, I try to stay as low as possible throughout the duration of treatment. If somebody, for example, on something like semaglutide has, plenty of benefit from a 0.25 or 0.5 milligram dose weekly, that's the level we stay at. It provides.
Whereas the standard protocol is you just keep titrating them up till they get to a higher level, right?
I would say, maybe standard in some practices, but definitely not mine.
Right.
If we have efficacy and therapeutic benefit at those low doses, keeping them there leaves more room to titrate up in the future if sensitization or tolerance happens to the medication. It also minimizes the risk for side effects. So in that way, I think that, small dosing or micro dosing, sometimes even breaking up a dose, a low dose a few times a week and doing a micro dosing approach like that can be very beneficial. And the reason
patients taking them for a long period of time.
Yeah. Mm-hmm. Including myself personally. I think that they're very beneficial. And they have the potential to really support a lot of different metabolic.
So you're taking a GLP-1?
Yeah, absolutely. I cycle back and forth between all three of them, or I cycle back and forth between semaglutide, tirzepatide, and I've utilized retatrutide as well. So I think that there's significant benefit. And personally, subjectively, I feel, substantial improvement in certain other things.
Do you think there's
outside of just
what are some of the other things you think has benefited you?
So I have Tourette's syndrome. And one of the things that I have as a result of that is some early degenerative osteoarthritic changes in my neck and my shoulders. That's like ultimately a chronic inflammatory process. They say osteoarthritis is not an inflammatory disease, but, when you look at the cellular level, it really is.
I think we now recognize that there's a big inflammatory component.
Exactly. Yeah. So, utilizing semaglutide at low dose has a pronounced benefit in reducing some of the pain signals and the inflammation that I feel on a regular day-to-day basis. And I've seen that sustained throughout the course of my utilization, which is, well over, a year and a half now. It's probably bordering on 2 years that I've been utilizing these therapeutics. And it also gives me, I think, a little bit of a leg up when I have patients come to me and they're looking to begin a journey with a GLP-1 peptide. I can explain to them what this feels like. I can explain, some of the potential side effects that they may encounter. And that gives them a little bit of confidence and understanding that they have somebody that, really can support them through that process.
So what are some of your other favorite peptides? And I'm thinking about things like BPC 157 and thymosin beta 4, et cetera.
Yep. BPC 157 is a must-have tool in the shed for regenerative healthcare practices, health span optimization practices.
Oral, injectable, both?
Both, yeah. BPC 157, it's a 15 amino acid sequence that is found naturally in human gastric juice. Essentially, when utilized orally, it can help to prevent and heal peptic ulcer disease. It's shown some, anecdotal improvements in healing mucosal injury in autoimmune conditions such as ulcerative colitis and Crohn's disease, which are both autoimmune inflammatory bowel diseases. It does help to modulate GABA, serotonin, and dopamine pathways in the gastrointestinal tract as well. So it can be an excellent option for balancing neurotransmitters and working with patients who have chronic anxiety and depressive symptoms. From the standpoint of blood flow and improvements in tissue repair, it does promote an enhanced synthesis of nitric oxide, and it supports nitric oxide pathways in the body. So it's very good at helping to support normal and healthy blood pressure. And it also upregulates VEGF, or vascular endothelial growth factor, which is associated with capillary genesis and the formation of new blood vessels. So it can be very beneficial.
I never heard about the connection between BPC and nitric oxide.
Yeah. One of the major pathways that it definitely works on, and that's why patients a lot of times will have these improved recovery times. I say patients, but a lot of times, clients who are in the bodybuilding or fitness or sports world will come to me, and they've had an acute injury, or they're getting a little bit older, and they're just feeling as though the recovery time is a little bit prolonged, longer than what it used to be. And they're having to wait a few days before they really feel like they can give it their all in the gym again. And so implementing a course of BPC 157 is, very much beneficial for improved blood flow, tissue recovery. It basically helps to enhance collagen and elastin formation and synthesis, and helps with collagen deposition that's actually organized, as opposed to disorganized collagen, which can promote fibrosis and scarring. And so,
what do you think about these guys from the gym that are buying these peptides like BPC online and administering them themselves?
Yeah, scary. I don't like it. I'm not a fan. I think that it's unregulated. It's a commercial grade product for research use only, or for animal use only. And that, there's many reasons why that's problematic. It could be adulterated. We never know the quality of the ingredients that are being utilized in those peptides. And the other aspect is that these are powerful agents. These are cell signaling agents. And so when you're ordering something, whether it's a nutraceutical or a peptide online, and you're ordering commercial grade, you as the consumer have no recourse if something were to go awry. If you were to use, an injectable peptide and you have a negative or untoward response, you have no recourse. You have no, ability to say, hey, I received this from my provider, and now I'm having X issue. So there's no consumer protection there, really.
Now, in terms of the FDA and these peptides, I know that the FDA has, in the last couple of years, has been limiting the use of peptides. Where are we with that?
Yeah, these are still categorized as, bulk substance biologics, a lot of the peptides that had formerly been utilized. And that has limited the number of compound pharmacies that are willing to engage in the process of manufacturing and supplying these peptides to patients. Now, fortunately, there have been several, I call them bastions of hope, because there are several compounding pharmacies out there that are still going full speed ahead with their compounding operations. And, this is an area that I'll let them and their legal teams, wrangle with. But for now, those are the only places where I will source peptides for patients. It's got to be a 503A compounding pharmacy.
So don't buy peptides online. You don't know what you're getting, and administer themselves. See a doctor, practitioner like yourself, and get them from a compounding pharmacy.
Exactly. Work with a clinician who's trained in peptides. Ideally, somebody who's gone through some sort of rigorous training or certification program. There's several programs out there for people who may be interested. So, A4M has a peptide therapy certification course. Dr. William Seeds with the SSRP, or the Seeds Scientific and Research and Performance Institute, has a phenomenal peptide therapy certification program. You want to work with a provider who knows what they're dealing with, who's familiar with protocols, who's familiar with the cellular mechanisms and the pathways that these peptides are really capitalizing on. And so, if you can, avail yourself of a practitioner who is comfortable in that realm.
Great. So let's wrap up this interesting discussion. Any final thoughts, and then tell us about your contact information?
Yeah, sure. Final thoughts. I'm going to hit everybody with my favorite peptide right now, SS31, also known as Lipoprotein. This is a powerhouse mitochondrial peptide. In the wake of COVID-19, in the wake of all of these changes that we're seeing in the American populace with regard to immune dysregulation because of the cascade of inflammation that resulted from metabolic syndrome, we need to have mitochondrial repair options. And so SS31 works on the inner mitochondrial membrane. It stabilizes a molecule, a compound known as cardiolipin, which basically is the scaffolding of the mitochondria, on which all of our proteins that are associated with energy generation and energy metabolism are situated. So that's, look up SS31. It has FDA research for treatment of certain mitochondrial disorders.
What dosage do you like for that?
Yeah, I usually start people on around 4 milligrams a day of SS31, and then I titrate them up to around 10 milligrams a day. The 4 milligram to 6 milligram is more of like a longevity, health span optimizing approach. And then for the people who have a lot of mitochondrial dysfunction, and they're really having poor energy output, I utilize the higher doses anywhere from 12 to even upwards. 10 to upwards of 12 or 15 milligrams a day at times. And so that is it's my favorite peptide. It's a powerhouse peptide. It can really help with cognition and focus. It can help restore sleep patterns and circadian rhythms, help with glucose metabolism, and energy optimization overall. So,
That's great. A good clinical pearl for us. I appreciate that. How can patients listening to this or watching this contact you?
So remedyfunctionalhealth.net is my website, www.remedyfunctionalhealth.net. On Instagram, I am at remedy.functional.health. Post there all the time. And my practice is here in Salisbury, Maryland. My number is 443-342-4141. And I do telehealth across the state of Maryland for people who are looking to revitalize and rejuvenate their life, and work with patients very closely here one-on-one locally. So, reach out.
That sounds great. Thank you so much.
Excellent. Hey, thank you, Dr. Weitz. I really appreciate it. You have a great day.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica White Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.